presentation, and again, sorry for the technical delay. My topic here is about thyroid diseases during pregnancy. And again, a reminder for all of you about EndoDMOS if you are interested in endocrinology and diabetes, please join our Twitter account ENDODMOS to have an update about diabetes and endocrinology, quick review as well if you have an interest in this field. So this is a quick reminder about the Twitter account. We'll go further now and to talk about thyroid diseases in pregnancy. We can classify them into hypothyroidism, hyperthyroidism, thyroid nodule, goiter, thyroid carcinoma, and postpartum dysfunction. We'll start with hypothyroidism during pregnancy. As we know, the clinical manifestation is usually the same as in non-pregnant ladies. Laboratory shows if there is no trimester-specific reference for TSH, use upper reference limit of 4. Use trimester-specific reference of 3 T4. If not available, measure total T4. Total T4 in pregnancy is 1.5-fold higher than in non-pregnant women. So this is how to approach thyroid function test in patients with hypothyroid during pregnancy. The screening, there is controversial about the screening. Interest in screening for thyroid dysfunction in pregnant ladies. The universal screening of asymptomatic pregnant during the first trimester is controversial. So maybe it is upon clinical decision of the physician. There is wide variation in screening practices. Some may investigate symptomatic patient with goiter, family history, or anti-TBO positive patients. What is the approach for diagnosis? If TSH above population and trimester-specific upper limit of normal or above 4, next step to measure free T4. And if TSH is 2.5 or above, measure antibodies again. If you diagnose overt hypothyroidism, it means high TSH with low free T4 below the reference range for pregnancy. And if the patient has labeled with subclinical hypothyroidism, it means high TSH with normal free T4. What about the antibodies status? It is very important to know that because women with subclinical hypothyroidism and positive anti-TBO have high risk of adverse pregnancy outcomes. Adverse pregnancy outcomes in euthyroid women with high serum TBO antibodies increase risk of fetal loss, preterm delivery, perinatal mortality, and large for gestational age. What about pregnancy complication in hypothyroidism, including all of the following, except this is a quick MCQ for all of you. Please participate. Do you think preeclampsia and gestational hypertension is the correct answer? B, large for gestational age. C, placental abruption. D, increased rate of cesarean section. So just think about it and give me your answer. It looks difficult, so I will go for the answer. It is B, large for gestation age. To classify the complication, risk is lower in subclinical than overt hypothyroid. This is a very important concept. And to classify the complications, maybe you have to keep in your mind the following. Number 1, preeclampsia and gestational hypertension. Non-reassuring fetal heart rate tracing, increased rate of cesarean section, perinatal morbidity and mortality, placental abruption, low birth weight, postpartum hemorrhage, preterm delivery, including very preterm delivery before 32 weeks, and neuropsychological and cognitive impairment in the child, like low IQ score. Again, think about this question. In hypothyroid, pregnant ladies, it is recommended to keep level of TSH below which of the following? A 1.5, B 2.5, C 3.5, D 5. Okay, I started to see some of your answers. Excellent in Q&A box. So you can participate in Q&A box if there is any technical issue in the chat box. You can participate, please, in Q&A box. Okay, I'm receiving some of your answers. Excellent. B 2.5. Yes, this is the correct answer. TSH below 2.5 is our goal for replacement in patient with hypothyroidism during pregnancy. Good fetal and maternal outcome depend upon treating maternal hypothyroidism. Look for indication of the treatment is our approach. What are the indications for treatment? If TSH more than 4, free T4 below the reference range, TBO positive or negative, treat. TSH again more than 4, free T4 within reference range, TBO positive or negative, treat. But don't treat or you have to go for antibodies if TSH between 2.6 up to 4. So TSH up to 4, the best option here to go for positive antibodies. If it is positive, this is indication for treatment. General dosing guidelines, TSH more than 4, low for free T4, using trimester specific range, for replacement dose 1.6 microgram per kg per day. TSH more than 4 with normal free T4, intermediate dose can be given 1 mcg per kg per day. And TSH between 2.6 to 4, maybe you can use 25 to 50 mcg daily. T4 should be taken on an empty stomach, which is levothyroxine, ideally 1 hour before breakfast, but few patients are able to wait this 1 hour. So a proper compliance with a proper advice should be given. This is to summarize what we just discussed. I have another question here. A scenario of 25-year-old female lady known to have hypothyroidism for 3 years. Dose is 100 mcg daily. Just did pregnancy test and it was positive. Her last TSH before 2 months was 2. She came to you asking your advice. So what is your proper action? A, do TSH after 2 months and no need to adjust levothyroxine dose. B, increase levothyroxine dose by 80% and ask for TSH level. C, increase levothyroxine dose by 30% and ask for TSH level. D, decrease levothyroxine dose by 30% and ask for TSH level. I'm waiting your answers. I will give you a few seconds to think about. Let's review your answers. Majority going with C, excellent. Yes, C is the proper answer here. So pre-existing hypothyroidism, the goal to keep TSH in preconception period less than 2.5. Early dose adjustment, newly discovered pregnant should be instructed to increase levothyroxine dose by 30% and notify the clinician. increase dose from once daily to 9 doses per week, which is 30% increase. Usually what we are doing in the clinical practice, ask the patient to double the dose during 2 days of during the weekend. Further dose changes are made based upon TSH measurement after 4 weeks until normalization of thyroid function test achieved. After initiation of levothyroxine, measure TSH in 4 weeks. Goal to maintain TSH less than 2.5. If TSH remain above the goal, increase the dose by 12 to 25 mcg per day. Measure TSH every 4 weeks during the first half of pregnancy because dose adjustments are often required. TSH can be monitored less often in the latter half of pregnancy. Once per each trimester also is a proper approach in such a case. I think we have again video here. Please concentrate.
Hello and welcome to Med Simplified. In this video, we will talk about hypothyroidism, that is low thyroid levels, and its effects on pregnancy. Then we will also discuss how you should manage your hypothyroidism during pregnancy. Pregnancy is a period that places great physiological stress on both the mother and the fetus. When pregnancy is complicated by endocrine disorders such as hypothyroidism, the chances of adverse outcomes increases for both the baby and the mother. Pregnancy causes major changes in the levels of hormones made by the thyroid gland. For that reason, thyroid problems sometimes can start or get worse during pregnancy or even after childbirth. The thyroid makes the hormones T3 and T4, which control our metabolism, which in simple terms is how your body uses and stores energy. When the thyroid gland doesn't make enough thyroid hormone, it is known as underactive thyroid or hypothyroidism. The symptoms of hypothyroidism can be confused with the hormonal changes of a normal pregnancy, such as tiredness and weight gain. So low thyroid levels can be easily overlooked in a pregnancy. If left untreated, hypothyroidism in the mother poses a risk for both the mother and the baby. A pregnant woman's thyroid hormones are vital not only for her but also for the development of her baby. Pregnant women with uncontrolled hypothyroidism can get high blood pressure, anemia, muscle pains, and weakness. There is also an increased risk of miscarriage, premature birth, or even stillbirth. In our previous videos about hypothyroidism, we have discussed in detail why hypothyroidism occurs, what are its signs and symptoms, and how is it treated. We have also made videos about what foods you should include and which foods you should avoid if you have hypothyroidism. So make sure to check them out by clicking the I button above. Let's first take a look at what are some common signs and symptoms you can develop if you have hypothyroidism, and then we will take a look at why thyroid hormones are so important for both the mother and the baby during a pregnancy. When the thyroid gland produces less thyroid hormones than it should, metabolism slows down and causes a variety of symptoms. At first, the symptoms of hypothyroidism may not be noticed, but over time these symptoms become more obvious and severe. These can include fatigue, weight gain, constipation, irregular periods, loss of sex drive, hair loss, brittle hair and nails, dry, itchy skin, difficulty in learning and memory, infertility, etc. The most common cause of hypothyroidism is an autoimmune disorder called Hashimoto's thyroiditis. The body's own immune system mistakenly sends out antibodies to destroy the cells in the thyroid gland. This may cause the thyroid gland to enlarge, and this is known as goiter. Hypothyroidism and goiter can also result from not getting enough iodine in your diet. Hypothyroidism can also occur after thyroid surgery or radioactive iodine therapy given to treat hyperthyroidism. In many cases, specific cause of hypothyroidism is not known. Thyroid hormones are vital for the development of brain and spinal cord of the growing fetus. In 1888, the Clinical Society of London studied the importance of normal thyroid function on the development of brain. Since that time, numerous studies with rats, sheep, and humans have proven that thyroid hormones have vital importance for various stages of brain development, including growth of the neurons, which are the main cells of our brain, and also for the development of the myelin sheath, which is like the covering of the neurons, and it is essential for their function. Studies have also demonstrated 60% risk of fetal loss if the hypothyroidism in the mother is not controlled. The fetus usually starts producing thyroid hormones when it is about 12 weeks old, but it still needs thyroid hormones before 8 weeks, as most of the early brain development occurs before 12th week. Until then, the fetus uses the thyroid hormones produced by the mother, and due to this, naturally the load on the thyroid gland of the mother increases, as it has to produce more thyroid hormones. It is estimated that the thyroid gland has to produce approximately 50% more thyroid hormones during a pregnancy to support the extra requirement of the fetus. Now let's look at some of the risk factors for hypothyroidism. Women are at increased risk of hypothyroidism during or after pregnancy if they are over the age of 30 or have past infertility or preterm delivery, a family history of thyroid or autoimmune diseases, type 1 diabetes or other autoimmune diseases, prior radiation treatment of the head or neck, past thyroid surgeries, presence of thyroid antibodies, mainly thyroid peroxidase antibodies. You have also an increased risk of hypothyroidism if you have goiter, which is enlargement of the thyroid gland. Now let's look at treatment of hypothyroidism during a pregnancy. The treatment for hypothyroidism is thyroid hormone replacement with a form of T4 hormone called levothyroxine. This drug is the same as the T4 your body makes and is safe for pregnant females. Before pregnancy, it is important that thyroid hormones are at normal levels. If you are already receiving levothyroxine to treat hypothyroidism, you should have your thyroid hormone levels checked before you try to conceive. If your TSH levels are too high, you may need to increase your dose of levothyroxine. You should delay the pregnancy until your disease activity is well controlled. Once a hypothyroid female becomes pregnant, the levothyroxine dose often must increase. The dose should be increased as much as 30% or more in the first 4 to 6 weeks of pregnancy. After that, it is important to monitor the TSH levels, and the goal is to keep it below 2.5. Now, 2 to 5% of females have subclinical hypothyroidism during the pregnancy. Subclinical hypothyroidism is defined as increased TSH with normal concentrations of T4 and T3, which simply means that the thyroid gland is struggling to keep the thyroid hormone levels above the normal threshold levels. Since multiple studies have shown that subclinical hypothyroidism is also associated with an adverse outcome for both the mother and the offspring, most guidelines recommend that thyroxine replacement should be done in females with subclinical hypothyroidism. The main test used to detect hypothyroidism is measuring the blood levels of TSH. An elevated TSH level usually means the thyroid gland is not making enough thyroid hormone, and the pituitary gland has responded by making more TSH to try to get the thyroid hormone levels where they should be. Other blood tests include measuring T4 hormones and thyroid autoantibodies. T4 is the hormone produced directly by the thyroid gland. It is typically low in patients with hypothyroidism. Thyroid autoantibodies are seen in patients with Hashimoto's thyroiditis. When you get pregnant, TSH levels, among many other tests, are included in the basic testing profile that every female has to go through when pregnancy is detected. So the bottom line is, untreated hypothyroidism during pregnancy is associated with adverse outcomes for both the mother and the baby. Hypothyroidism during pregnancy could result in abortion, especially in early pregnancy. It can also result in recurrent pregnancy losses, anemia, preeclampsia, gestational diabetes, postpartum bleeding, and an increased risk of cesarean sections. So it is very important to manage hypothyroidism properly during pregnancy. Make sure to watch our playlist on thyroid health, in which we have discussed about many other topics. I hope you like the video. Make sure to share with someone who you might think can benefit from this video. Thank you so much for watching. If you want to support Med Simplified, you can become a member of this channel or join our community at patreon.com/medsimplified. Thank you so much for watching and see you in the next video.
So by this we finished the hypothyroid, and now it's the time to go for hyperthyroidism. And before we elaborate more, I want you to answer this question. What is the most common cause of hyperthyroidism during pregnancy? Do you think A, gravis, B, toxic nodular goiter, C, toxic multinodular goiter? Okay, we are seeing A and B, and actually, usually A, Graves' disease is the most common one. Overt hyperthyroidism with low TSH and high FT4 is usually uncommon, but Graves' disease and beta HCG mediated hyperthyroidism, most common causes of hyperthyroidism. Beta HCG mediated transient in the first half of gestation and less severe. The Graves' disease less severe in later stages of pregnancy due to reduction in TSH receptor antibody concentration. Examples of beta HCG mediated hyperthyroidism, gestational hyperthyroidism, transient thyrotoxicosis, hyperemesis gravidarum, and trophoblastic hyperthyroidism. The next step here, which is the following, or scenario, question, which is the following complication expected in pregnancy if complicated by poorly controlled hyperthyroidism? Heart failure, renal failure, or hepatic failure? Okay, I see many going with C, but actually heart failure is the correct answer. Let's discuss pregnancy complicated by poorly controlled hyperthyroidism. Includes spontaneous abortion, low birth weight, preeclampsia, premature labor, stillbirth, heart failure, fetal and neonatal graves due to transplacental TSH receptor antibodies. Usually the clues in the clinical practice include fetal pulse more than 160, goiter, advanced bone age, poor growth, or cardiac failure. All fetuses of Graves' mother should be monitored for these signs. And to establish diagnosis, you have to take proper history and examination for classic signs and symptoms. Features distinguish transient hyperthyroidism of hyperemesis gravidarum from hyperthyroidism of other causes like Graves include vomiting, absence of goiter, ophthalmopathy, absence of other common symptoms and signs of hyperthyroidism, tachycardia greater than 100, hyperdefecation, and muscle tremor. Lab, usually we have suppressed TSH less than 0.1, undetectable less than 0.01 TSH value, and high FT4 T3 that exceed reference range of pregnancy. FT4 minimally elevated and T3 may not be high in hyperemesis gravidarum. FT4 and FT3 are unequivocally high in hyperthyroidism from gravis. Thyroid ultrasound may help to detect the Doppler flow. Graves' disease high blood flow is observed. Paleness or postpartum thyroiditis low blood flow. The treatment, beta HCG mediated hyperthyroidism need no treatment because it is transient, just monitoring. Indication for treatment of true hyperthyroidism include symptomatic moderate to severe Graves' disease, toxic adenoma, and toxic multinodular goiter. Usually TSH below 0.01 and high trimester-specific FT4. Graves or nodular thyroid disease treatment are limited because therapy may be harmful to the fetus. Keep free T4 in high normal range for non-pregnant women using the lowest dose. This requires assessment of free T4 frequently with appropriate adjustment of medication. And the drugs, usually you can use beta blocker to control symptoms. First trimester, as we mentioned before, PTU, then after the first trimester, go for carbimazole or methimazole. Dry ablation, contraindicated. Thyroidectomy may be indicated, especially in the second trimester in a special situation. Goals and monitoring persistent but mild hyperthyroidism in mother in attempt to prevent fetal hypothyroidism due to drugs, since the fetal thyroid is more sensitive to the action of antithyroid drugs. Overtreatment of maternal hyperthyroidism with thioramide can cause fetal goiter and primary hypothyroid. Poorly controlled hyperthyroidism during pregnancy lead to transient central hypothyroidism due to suppression of fetal pituitary thyroid axis. What about how to deal with goiter? Goiter during pregnancy is common in region where iodine intake is low. Any thyroid growth during pregnancy should be considered potentially abnormal, requiring further investigation with TFT and possibly thyroid ultrasound. Nodule, pregnant women with thyroid nodule should be evaluated in the same way as she is not pregnant. TSH and ultrasound should be performed. Thyroid radioactive radionuclear medicine contraindicated during pregnancy. Fine needle aspiration may be indicated according to the guidelines, and it is safe to be done. And usually, as I just mentioned, it is better to go for thyroid surgery if needed in the second trimester. And finally, how to deal with thyroid carcinoma. Women with differentiated thyroid cancer require surgery. Thyroidectomy is usually delayed until postpartum to minimize maternal and fetal complication due to indolent nature of thyroid cancer. Surgery during pregnancy is indicated for rare patients with large or more aggressive or rapidly growing cancer or presence of extensive nodal or distant metastasis. And the best time, as we mentioned, is the second trimester. Postpartum thyroid dysfunction is usually with the thyroiditis, and in hyperthyroid phase, beta blocker again is the best to be given to control the symptoms, and no role for antithyroid drugs in this situation. If the patient went for hypothyroid phase, maybe the replacement with levothyroxine is the best option in this situation. Women may develop Graves' disease postpartum or experience an exacerbation. In addition, women in remission after antithyroid drug therapy have a higher incidence of relapse during postpartum period than at times unrelated of pregnancy. Take-home message. This is the last message. The evaluation and treatment of pregnant women with thyroid disease parallel that of non-pregnant women and men, but present some unique problems. And again, reminder for Twitter account DMOS if you are interested. Thanks for listening. We are concluding the second day today by this slide. Hope to complete your course tomorrow, and hope again to see you in another event or course soon. والسلام عليكم ورحمة الله.